Welcome to this first lecture of the module for physiotherapy and the management of people with neuromuscular conditions. So in this first lecture there'll be an overview of the neuromuscular conditions. We'll classify them according to the site and type of pathology, and I'll briefly describe some key, the more common diseases that you may come across, and we'll look at the prevalence and the presentation of those featured diseases. And then right at the end there'll be a slide with some links to resources for further learning. So there are approximately 600 different types of neuromuscular diseases, so they're incredibly varied. So classifying them is tricky. So what we tend to do is look at actually the site of the disease process in order to help us do that. So if we start at the top of the peripheral system, the anterior horn cell, which obviously is in the spinal cord, so it does just go into the upper motor neuron system. So for conditions such as motor neuron disease and polio, that's where this condition occurs. Then there are diseases of the peripheral nerves, for conditions like Guillain-Barré or Charcot-Marie-Tooth disease, conditions of the neuromuscular junction, for example myasthenia gravis, and then there are diseases of the muscle tissue itself, which due to different types of myopathy. And amongst these 600 odd diseases, there's a massive variation in the progression, the presentation, and the severity of how they present. So if we start looking at some of the anterior horn cell diseases, so as mentioned, it isn't strictly a lower motor neuron, as the cells obviously originate in the spinal cord, but some of the features of those conditions are very similar to lower motor neuron diseases, but there can be some upper motor neuron signs in some of them, for example spasticity or brisk reflexes. So in terms of different types, there can be inherited types of anterior horn cell disease, such as some types of ALS. There's also spinal and bulbar muscular atrophy, and SMA types 1 and 2, and there are acquired types as well, for example by infection with poliomyelitis, but there are also idiopathic types of some of the other motor neuron diseases. So if we look first of all at ALS, so this diagram shows the site of the problem. And here you have the motor neuron go from the cell body in the anterior horn down to the muscle, and here you get dying back of that, and there's associated wasting and weakness as the muscle becomes denervated. So with ALS, it's relatively rare. It affects 5.2 per 100,000 people. So as I've said, it affects the motor neurons in the PNS and the CNS, and upper motor neuron signs can be observed. And it's most commonly sporadic, but there are some rarer cases where 5 to 10% where it's an inherited pattern, and it's down to the mutation of the SOD1 gene. So if you look in the bottom right hand corner of the screen here, you can see the pathway of the mutant SOD1 gene, and how it actually affects the motor neuron and how that dies back because of excessive glutamate. In the spinal form of ALS, there's progressive limb wasting, and the life expectancy is about 3 to 5 years. But there's also a bulbar form, and there dysarthria and dysphagia are key features, and there the life expectancy is shorter, of 2 to 3 years. Now ALS is a rare condition, but it is greatly feared because of its life-shortening and fast progression. It's an adult onset motor neurone disease, and you can see in the photograph here evidence of the distal wasting. They're having to hold on to them because of the plantar flexor weakness and difficulty standing still, but also weakness of the hands. It's a very slow progression of motor weakness, unlike ALS. You can also get bulbar dysfunction with this condition, and it's down to a CAG repeat, so 3 of the amino acids on DNA. So there's a repeat expansion on the androgen receptor gene, and that's what causes the SMA and Kennedy's condition. Now looking at polio, this is the cause of polio in the acute stage, and that's the polio virus. And what happens, that actually leads to destruction of the anterior horn with the acute infection, and that often leads to very severe muscle weakness and can lead to respiratory failure. And you can see the old photograph there from the polio epidemic in the earlier last century, where this person's in an iron lung to support breathing because of respiratory muscle weakness. But often following a period of recovery, people will improve, but often are left with the level of disability. Now, of course, we know that the polio vaccine has been very successful in the Western world, and all over the world actually, because there's only 3 countries left in the world now that have polio. However, our polio survivors, who are running into middle and older age, are running into secondary problems. So if we look at this diagram here on the left, they start off normal, then they contract the polio virus, and that leads down to paralysis. Then after that there's the period of recovery, and there's a period of stability of several decades. And then for some reason later on, the second wave of problems occurs, known as post-polio syndrome. And that can affect individuals as much as 40 years after the initial polio infection. And people complain of excessive fatigue and lethargy, muscle pain, and their functional level deteriorates. And the causes are uncertain. There are some theories which we'll look at, but it doesn't involve reactivation of the polio virus. So this is one model that suggests the reason why people run into problems later, and it's a model of denervation. So in the top left-hand diagram you can see motor neurons innervating muscle fibres in the normal situation. Then next, a bit further down, after acute polio, 2 of the neurons have been affected, so you get dying back of those motor neurons. And then during the recovery phase, the remaining motor neurons will sprout and will take over the innervation of the muscle fibres that are left. And so those motor units become enlarged because of that. And then what happens with post-polio syndrome is as we age, we lose some of our muscle fibres. And there may be other reasons. There's a theory that excessive oxidative stretch, perhaps through overwork and over-exercise, may cause some dying back of those remaining motor units. And that it could be aging, it could be overwork. It's still not entirely clear. But anyway, these enlarged motor units are a bit more vulnerable, and if you lose one, you lose quite a few muscle fibres as part of that enlarged motor unit. So this is another model looking at post-polio syndrome. So at the top there you can see overwork, aging, other immunological processes, impaired motor neurons, and that leads to the motor unit dysfunction. And that can lead to atrophy, muscle cramps, spasms, leading to further weakness. And then you also, on top of that, have musculoskeletal disuse. That also contributes to progressive weakness because of people's disabilities. People with polio have been seen to be less active. And then overall you have decreased function and fatigue and pain and progressive issues. Now moving down to the peripheral nerves. So these a big group of peripheral nerve diseases are the polyneuropathies. And you can see in the diagram here a motor neuron going down to the muscle fibres and the myelin sheathed around the main axon. There are inherited polyneuropathies. There are acquired ones, some of them down to metabolic problems such as diabetes, prolonged alcohol use, vitamin deficiency, and B12 is particularly relevant here. There's inflammatory polyneuropathies and infection. So if we look at examples of demyelinating polyneuropathies, so this is where the myelin is stripped back off the axon. One example of a demyelinating polyneuropathy is Guillain-Barré syndrome. Another type is chronic inflammatory demyelinating polyradicular neuropathy, or CIDP. Charcot-Marie tooth disease type 1 is also a demyelinating neuropathy, and we'll look a bit more closely at those three conditions a little later. But what happens in the longer term, particularly in CIDP or Charcot-Marie tooth disease, which are longer term conditions, is that in the top diagram you can see the myelin's been stripped away, and you have a conduction block because the action potential isn't able to continue propagating. But in the bottom diagram, over time, the voltage-gated ion channels will tend to proliferate down that part of the axon to try and maintain some conductivity. But what you find happens is it's slowed because you haven't got normal saltatory conduction, and neurophysiological testing will show a slowed action potential in people with demyelinating neuropathies, and often that's diagnostic. Then there are axonal neuropathies, so where the axon itself is damaged or diseased and you get dying back of that. Charcot-Marie tooth disease type 2 is an axonal polyneuropathy. Also diabetic neuropathy, where the smaller fibres are often affected. Alcohol or drug-induced neuropathies are often axonal as well. And then there's critical care polyneuropathy, where people who've had long periods on intensive care units with sedation or paralysis agents can be vulnerable to critical care polyneuropathy. And then an example of an infective cause of axonal neuropathy is leprosy, which is rare in the UK but is seen across the world. And you can see in this bottom diagram here that the axon is degenerated back. Now, with neurophysiological testing, normally you would see you stimulate a mixed nerve, and you get a big response, a compound muscle action potential, which is due to the multiple motor units you're stimulating. If you have axonal degeneration, some of those motor units won't be there and won't be contributing, so you get a reduction in the size of the compound action potential. So, looking more closely now at Guillain-Barré syndrome. Guillain-Barré syndrome is the most common form of neuromuscular paralysis in the developed world. Its full name is acute inflammatory demyelinating polyradicular neuropathy, and it's a condition of the immune system where you have sensitization of the T lymphocytes to the myelin protein following a viral or bacterial infection, and those T lymphocytes then attack and destroy the myelin. And certain infectious agents have been indicated. So, for example, Campylobacter jejuni is a bacteria that's been implicated as a cofactor in about 1 in 1,000 cases. And again, just to remind you of what happens within the motor nerves, but this also happens with sensory neurons as well, is that conduction block because of the saltatory conduction is interrupted in the acute situation. So with Guillain-Barré syndrome, classically you see pain and symmetrical paresthesia, sensory loss in a glove and stocking distribution. You get ascending symmetrical limb paralysis. If it ascends higher in the more severe cases, you can get trunk weakness of the intercostals and abdominals. In very severe cases, you can get weakness of the orofacial and laryngeal muscles and diaphragmatic weakness, and this is often when people need critical care. With the trunk weakness, you can get reduced maximal expiratory pressures and impaired cough. With the bulbar weakness, bulbar dysfunction and impaired cough because of reduced laryngeal closure. And with bulbar dysfunction, people can be vulnerable to aspiration. And diaphragmatic weakness will give impaired cough and also reduced inspiratory volumes. And if a person's vital capacity drops below 15 to 20 millilitres per kilogram, that's when they may need ventilating. Postural hypertension is also a problem which occurs with GBS, particularly important for us physiotherapists during the rehabilitation phase, and when we start getting people up and moving, they may have some quite marked postural hypertensive episodes. So the disease course, the acute phase happens often quite quickly, and this is where you get a deterioration of up to 4 weeks, and they deteriorate to a point called the nadir, which is the worst set of presenting symptoms in that person. After the nadir, they will improve or plateau to start off with during the subacute phase, and then improve during the recovery phase, where you start to get remyelination of the affected nerves. And that phase can take from a few weeks up to a few years. And not everybody makes a full recovery, and how full the recovery will depend on how much axonal damage there's been, because the axons don't last particularly well when there's no myelin. The Schwann cells that create the myelin and the axon have a lot of growth factors that exchange between the two. So the longer you have a denuding of the axon, it's not a great situation for its survival. Medical management is really important during those early phases, and common drugs that are given are intravenous immunoglobulins. Some people may have plasma exchange in order to regulate and calm down the immune process. So this is CIDP, chronic inflammatory demyelinating polyradicular neuropathy, and a little bit like Guillain-Barré, you have dying back of the myelin, and you can see in these two diagrams, the top one shows normal axon with the myelin around it, and the bottom one you can see where the axon has been denuded by the disease process. And it's again a relatively rare condition, 1 in 100,000 people, and more common in men. You get distal sensory loss, you can get symmetrical muscle weakness, but sometimes it can be asymmetrical. And you often get gait abnormality relating to this. Foot drop is very common, distal weakness. About 20% of people have pain. And often the onset can be quite gradual and insidious, unlike GBS where there's a definite point where the deterioration starts. And a little bit like in multiple sclerosis, which of course is an inflammatory condition of the CNS, in CIDP it can have a relapse remitting or a progressive course, and it sometimes does act a little bit like MS of the peripheral nerves. So diagnosis, as discussed with some of the other slides, neurophysiological testing will be able to show whether or not there's a slowing of the conduction velocity of the nerves, and also if there are increased inflammatory markers or immune markers. And the medical management, often people are given steroids or intravenous immunoglobulin, which are given at regular intervals, can be a very important way of managing CIDP. Methotrexate is been tried in some people as well, and some of the MS drugs that have proven efficacy in multiple sclerosis are now being tried out in CIDP. Charcot-Marie tooth disease is the most common inherited neuromuscular disorder, and it's caused by about 80 different genes, and it has a prevalence of about 1 in 2,500 people, so it's relatively common compared to most of the other neuromuscular diseases. It can be both demyelinating or axonal, depending on which gene has been affected. And the most common gene mutation accounts for 60% of cases, and that's where there's a duplication of the peripheral myelin protein 22 gene. So there's too much myelin wrapped around the nerve, and it doesn't pack down properly, and so it doesn't function well. And so you can get dying back of the motor and sensory nerves from the periphery. That particular type is autosomal dominant, but there are X-linked varieties, and there are some rarer recessive types as well. And diagnosis relies on good family history, also neurophysiological testing to see if it's demyelinating axonal, and you'll be looking at clinical presentation as well. And there are genetic tests now for a certain percentage of types, but not all types, particularly the axonal types. There's only about 20% of genes known. This is just a reminder of the other types of inheritance. Obviously we looked at X-linked inheritance earlier, but top left, that's autosomal dominant inheritance, and most types of CMT have that, where one affected parent will pass on one gene, and the children who inherited that one gene will present with the condition. As I mentioned, there are rarer in recessive types where both parents have to have the affected gene. If one gene is passed on, as in with the two middle children, they'll be carriers but they won't be affected, but the child on the far right will have picked up a copy from each parent and will present with the condition. So CMT has a very slow progression. They change over years rather than months. There's distal sensory loss and also distal weakness and wasting that occurs, and you get this classic foot and hand deformity. So here this is the pes cavus deformity of the foot, which is most commonly seen when CMT starts in childhood. Some of the axonal types start a bit later on in life and you see this a little bit less. But the picture on the right shows the callus formation on the lateral border of the foot, which is commonly seen with pes cavus. And that picture of the hands shows the classic wasting and claw hand and wasting of the thenar eminence, because thumb opposition can be very affected. Then there's gait abnormality. So where you have the distal weakness, foot drop is very common, and people will walk often with a steppage gait to try and compensate for that and reduce tripping and falls. Moving now to the neuromuscular junction. So myasthenia gravis is the most commonly known condition of the neuromuscular junction. There are congenital types, which are due to genetic mutations, and then there's the acquired MG, which is autoimmune. And so the neuromuscular junction, close up, on the left is a normal situation, so you can see the terminus of the nerve there. Acetylcholine is released by the vesicles of the nerve. It crosses the synaptic cleft there, and the acetylcholine links into the receptors on the muscle side, which helps to propagate the action potential. And on the right you can see there's autoantibodies which are blocking those receptor sites, and that then prevents the acetylcholine from working to then propagate the action potential. And so classic sign of myasthenia gravis is muscle fatigability, because with continued contractions that situation just worsens and worsens. Symptoms can really fluctuate, and that can be difficult to pick up on sometimes, in that people can have good days or bad days, or can fluctuate within a day. There can be quite specific muscles involved, so there are ocular myasthenia gravis type symptoms where ptosis is common, and you can see that in the photograph to the left. But there's also times where it's more bulbar and limbs affected. The facial expression can be very flat, and this can actually be quite an issue for people with myasthenia, where they feel that people think that they are disinterested or aren't expressing emotion, but actually it's because of the weakness of the facial muscles. And then when people try to smile, there's the classic myasthenic snarl, because the orofacial muscles are not able to correctly position the mouth. Then moving down to the muscle. So myopathies are the diseases of the muscle tissue. They can be inherited, like the muscular dystrophies, and on the right that's a picture of some of the proteins within the muscle membrane, and we'll come back to that later. There are mitochondrial myopathies. Now, the mitochondria provide energy to all of the cells of the body, but in tissues like muscle, there's a lot of them because of the high energy requirements of muscle tissue. So if there's problems with the mitochondria, if they're mutated or they're not working properly, then myopathies are common. You can also have acquired myopathies. You can have inflammatory myopathies such as polymyositis, or critical illness myopathy, again where prolonged periods in intensive care, use of paralysing agents and sedation can leave people vulnerable to myopathic changes. So looking now more carefully at the muscular dystrophies, and there's a number of different types, and they're defined as inherited muscle destroying diseases, and they're genetically determined myopathies, unlike some of the other types. So back to that picture of the muscle membrane. And these sort of very colourful blobs are basically proteins that have important functions within the muscle membrane, and some of them are very large. And they all have distinct functions within the muscle membrane, and the protein structure is determined by specific genes that are inherited. So if you have abnormal genes, you then have abnormal proteins, the shape is altered, and that can lead to disruption of the muscle membrane. You get leakage of the calcium ions into the sarcolemma, and gradually the muscle fibres will degenerate. And cardiac muscle can be affected, it's not just skeletal muscle. So there circled is dystrophin, that long protein you can see. And so the most commonly known type of muscular dystrophy is Duchenne's muscular dystrophy, and that's where there is a lack of dystrophin. There's very little dystrophin within the muscle membrane, which leads to the symptoms of that particular condition. So there's been a lot of work done lately on imaging people with nerve and muscle disease. And what happens as these diseases progress and there's destruction of the muscle tissue, is that tissue is then invaded by fat. It's called fatty atrophy, and there's fatty infiltration. And on the left you can see somebody with quite mild muscular dystrophy, and in the long picture you can see that the quadriceps muscles, some of the muscles in the lower leg, and then underneath that there's the cross section of the thigh, and you can see the sort of quite dark healthy muscle, but just medially you can see that it's got a bit white, and that's where there's starting to become fatty infiltration in some of the medial muscles. And then lower down that's a cross section of the calf, and again you can see lots of speckled white within the muscle tissue where there's infiltration of fat into the calf muscles. In the middle that's somebody with more advanced disease, and you can see that thigh cross section. Although some muscles are spared, a lot of them are still very white where the fat has invaded. And then again lower down the cross section of the calf. And on the right is somebody with very severe disease, and there's actually very little contractile tissue left in both the thigh and the calf. And it seems with certain muscular dystrophies that some muscles are more at risk of atrophy, and some are more spared, and it's not quite clear why some are more affected than others, even within the same body segment. So now this is a closer look at Duchenne's muscular dystrophy, which is has onset in childhood, and it affects 1 in 3,500 live male births, so it's relatively common. Onset is aged 3 to 4 years, and that's when problems are first noticed. And as mentioned, it's a problem with the dystrophin protein and the gene coding for it, and there's very little dystrophin in the membrane. It has an X-linked inheritance, and the early signs are difficulty walking and some developmental delay. And you get pseudo-hypertrophy of the muscles, the proximal muscles, but also of the calf muscles. You can see, particularly the middle boy, he's got quite chunky quads and chunky calves, but actually it looks like it might be hypertrophy of the muscle, but actually there's a lot of fat in there, and that's why it's pseudo-hypertrophy. And the weakness that they develop, you can see the postural problems developing as the children get older, with that hyperlordosis starting, and there can be cardiomyopathy as well. And although this is a disease of childhood that our paediatric colleagues are very familiar with, because of very good medical management and rehabilitation now, these boys are now surviving into adulthood, and there are many more men now in our services with Duchenne's muscular dystrophy, and often very severely affected with postural problems, often needing respiratory support, joint contractures, etc. So we will see some of these men transitioning into adults services. Oh, and just to say, because this is a myopathic condition, you will see a diminution in the reflexes, but sensation is intact, and that's important to know when you are managing these boys. Unlike the polyneuropathies where there can be sensory loss, sensation is intact. Now this is a common sign that you see in muscle disease, a Gower's sign, when there's proximal weakness, and it's sort of a classic telltale trick movement where there's proximal weakness, a boy will walk his hands up the leg in order to extend up, and you sometimes see people transferring this way, transferring on all fours to be able to move from chair to chair. So on the left here, Becker's muscular dystrophy. So this is actually very similar to Duchenne's in that the dystrophin gene is also affected, and it's X-linked, but it's the dystrophin isn't completely gone. There is some dystrophin still there. It's less severe, and so because of that, it's later onset, and walking is preserved for longer. On the right here is Emery-Dreifuss muscular dystrophy. This is where the proximal muscles are involved. People often get contractures of the flexors of the upper limb and the Achilles tendon, and there are 3 known genes that cause Emery-Dreifuss that are X-linked, that are autosomal dominant, and the recessive types as well. This is somebody with limb-girdle dystrophy. It's a later onset, often with proximal distribution. You can see in the diagram the very winging scapulae. Often they get a lot of gluteal weakness as well. Hip extension is very weak. It may be asymmetrical, and disease may arrest in middle age, and it is quite a common gene. And limb-girdle muscular dystrophy type 1B is a type that has autosomal dominant inheritance. This is another common type of adult onset muscular dystrophy, which is facioscapulohumeral dystrophy. It affects the face, the spinal muscles, and the quadriceps. Again, the disease may arrest later in life, and the life expectancy is normal, and it's 1 in 20,000 people get FSH. There's a higher incidence in men, and there can be some asymptomatic cases in females. And it's autosomal dominant, although it's quite common to get spontaneous mutations within one person. That's known as a de novo dominance. So in 10 to 30 cases it can start in that person and then is inherited in an autosomal dominant fashion to the subsequent generations. So in the top photograph you can see the very classic facial weakness, and that's a horizontal smile. The middle picture you can see very marked wasting around the deltoids and the scapular muscles, and then at the bottom there you see this quite classic hyperlordosis, where as proximal weakness occurs, people are trying to balance back and eventually become so lordosed in their spine. And often, surprisingly, this can be relatively pain-free, but where it starts to cause pain, it can be difficult to manage, because if you try and brace their back upright, often they won't be able to stand. And then there's something called Beaver's sign. So if you look at somebody's umbilicus and you ask them to cough, the umbilicus isn't supported because of proximal weakness. It's not supported by the abdominal muscles, and the umbilicus shoots upwards. Then this is scapuloperoneal muscular dystrophy, where there's the proximal upper limbs and the distal lower limbs are involved with childhood onset, and there may also be cardiac involvement. And then another more common type, which is myotonic muscular dystrophy, and that's when you exhibit myotonia, which is where relaxing the muscles after a muscle contraction is very difficult. You also get facial atrophy, proximal limb weakness, and cognitive involvement. And this little photograph shows the finger muscles quite frozen after a contraction, and it takes a while for them to relax out because of the myotonia. And this photograph shows the classic facial atrophy and proximal limb weakness. So the investigations that are important for muscular dystrophy are the family history, to look at the type of inheritance, and also what's commonly seen is raised creatine phosphokinase, or creatine kinase, which is a marker of muscle damage in the blood. EMG studies can be important, and also muscle biopsy to see exactly what's going on in the muscle tissue, and also cardiac tests. And genetic tests are available for some of the genetic types. Now moving on to inflammatory myopathies. An example is polymyositis, inclusion body myositis, or dermatomyositis. And these are idiopathic inflammatory conditions. So starting off with polymyositis and dermatomyositis, and these often start in adulthood, and you get weakness of the proximal muscles, and the pharyngeal muscles can also be affected. And dermatomyositis has the classic skin rash that you can see in that bottom photograph. And they're normally autoimmune diseases, and they're not sure why they happen. And again, a little bit like with the dystrophies, you get raised creatine kinase levels, indicating muscle damage. Now, inclusion body myositis, although it comes under the umbrella of the inflammatory myopathies, looks a little different. It comes on in much older age, and although it's an autoimmune disease, you don't have the same levels of inflammation, And when they've looked at it more closely, it seems that it's a problem of protein build-up and protein misfolding and inflammation within the endoplasmic reticulum of the muscle cells that causes stress. And what you see classically in the photograph below, a weakness of the quadriceps and a lot of wasting there, and the long finger flexors, and you can see the wasting of the forearms. And the pharyngeal muscles can be involved as well. And again, you can see raised serum creatine kinase levels. And actually, there's some people that say that because of the pathology of protein buildup and protein folding and this endoplasmic reticular stress, that it is a little bit like the Alzheimer's of the muscle tissue. So that ends that lecture, and in your resources you'll be able to download a PowerPoint slide that has these links on. So you can click on those links and they'll be able to take you to some online resources. So there are some key papers that may be able to help you, and you can link to those. And then further down the slide you'll see links to some of the support groups, and a lot of them have very useful information for physiotherapists to be able to use. Thank you for your attention.